This begins the podcast on the child with altered cardiovascular and hematological status. The concepts we'll be discussing deal with perfusion and cellular regulation. General concepts of perfusion that we'll discuss is central perfusion and peripheral perfusion. So central perfusion is generated by cardiac output. It's the amount of blood pumped by the heart each minute. The central perfusion propels blood to all organs and their tissues. Tissue perfusion refers to the volume of blood that flows through target tissues. Peripheral tissue perfusion is present when the patient's extremities are warm with appropriate color and appropriate pulses. This is a review of the cardiac anatomy. So you need to familiarize yourself again with where different valves are and what the normal flow through the heart is so that you can understand when something is abnormal. So again, normal heart function. Basic EKG, which I know you're now getting in 251. So you can, be able to look at an EKG and determine what is normal and abnormal. Here's a picture of normal sinus rhythm, and it tells you what that means based on age. You can see your newborns 100 to 180, toddlers 80 to 150, preschool 70 to 120, school age 70 to 110, and by your adolescent, we should be in that 60 to 100 range. Sinus bradycardia, sinus tachycardia. So we're going to discuss two cardiac abnormalities that deal with perfusion, and their ventricular septal defect and tetralogy of Fallot. When you have altered perfusion, some of the symptoms that you can visualize on right-sided heart failure would be edema, liver engorgement, weight gain, and neck vein distension. With left-sided heart failure, you can see tachypnea, dyspnea, exercise intolerance, orthopnea, cough, cyanosis, wheezing, rales, retractions, and nasal flaring. Children compensate for altered perfusion by becoming tachycardic. You can see cardiomegaly, gallop, murmur, be diaphoretic, fatigued, or show failure to thrive. Preload and afterload. So preload is affected by venous blood pressure and venous rate of return. Congestive heart failure is the number one cause of congestive heart failure in kids is congenital heart defects. So sometimes these can be picked up on physical exam or diagnostic studies like chest x-rays, Holter monitors, echoes, transesophageal echoes, cardiac catheterizations. And on the cardiac catheterization, the O2 sat, the pressure changes noted, cardiac output, stroke volume, and anatomic abnormalities. Assessment tools, we can talk a little bit more about this in class, but the echocardiogram, the cardiac cath, and the Holter monitor. Congestive heart failure signs and symptoms, tires easily, especially during feedings, and that's one of the big symptoms you'll see in the infant. Weight loss or gain, irritability, tachypnea, tachycardia, nasal flaring, grunting respirations, retractions, cough, crackles, periorbital or facial edema, jugular vein distension, but you will not see that in the infant. That would be the older child. Low urine output, clubbing, and chest pain. The goal of medical management is to increase the heart efficiency, and drugs like digoxin, your ACE inhibitors, beta blockers, and pacemakers will help to do that, or by removing excess fluid, which is diuretics, and then we usually have to supplement with potassium because of the depletion of the potassium from the diuretic. Nursing management is to administer medications and monitor for effectiveness. You want to assess apical heart rates, monitor potassium levels. We usually like to keep them in the higher to normal levels in somebody with a cardiac issue. Monitors I's and O's. Remember your daily weight so you have the most accurate depiction of whether a child is maintaining their I and O. You want to maintain oxygenation and cardiac function, so having oxygen at the correct rate, monitor pulse ox, calm and quiet the child, maintain at least a semi-Fowler's position in a child who's having respiratory and cardiac issues. You want to maintain rest, so uninterrupted rest times. Feeding shouldn't last more than 20 minutes, so often we give them more a high caloric formula since they can't maybe eat as long to get the calories. We give them a more dense calorie formula. You want to do frequent small feedings, rocking, adequate burping. You want to foster development. You want to make sure that we're maintaining their milestones as much as possible by using developmentally appropriate toys to stimulate fine motor movement, rattles, blocks, stuffed animals, dolls. We want to encourage sitting, standing, or walking for short periods of time to promote that gross motor development. You want to encourage talking, singing to help promote language skills. So we're trying to keep them on track as much as possible, even though there are other issues. Teach feeding techniques, feed the infant at a 45-degree angle, maybe use a car seat, burp frequently. We talked about the increased caloric formula. They may need a feeding tube if we're not able to absorb enough nutrition by feeding them normally, and try to prevent constipation because it's a strain on the heart, obviously, to strain if they're constipated. You need to give good emotional support to the parents. We want to allow parents to express their feelings, make sure we're explaining all procedures, keep parents informed, and refer to appropriate support groups as necessary. With congestive heart failure, we want good community care, so we want to teach parents the signs and symptoms of heart failure. Sometimes it's overwhelming for the parents for us to use the term heart failure. So you might not want to use that. It can be frightening. So you want to tell them, reasons to return, things to look out for, reasons you'd want to come back or call the doctor. Teach parents how to administer medications, the rationale, like with digoxin, we need to monitor heart rates. And if the heart rate's below a certain number, given and whether it's an infant or a child, they wouldn't want to administer that medication. Make sure they're doing apical heart rates, and also cover adverse side effects of medications with them so they can be on alert for those as well. Pulmonary hypertension is elevation of the pulmonary artery pressure at rest. You can have dyspnea with exercise, chest pain, syncope. They usually require oxygen, vasodilators, calcium channel blockers, IV prostacyclin, inhaled nitric oxide. We'll discuss this a little bit more in class. Pulmonary hypertension is called orphan's disease. We really don't know what the cause always of this is, especially in infants. A lot of times it gets to the point where they may require a lung transplant, but they don't always do well with a lung transplant either. And we'll talk about this a little bit more in class. Emotional support, education, financial support. Pulmonary hypertension, the meds can run thousands, like $25,000 a month for them to be on continuous IV infusions of these medications. So you need to help try to set them up with groups or resources that will pay for that. They need a lot of preparation to perform complex therapies and good follow-up care. Congenital heart defects is not one diagnosis. There's many. I think there's a worksheet in your packet of other ones that we are not going to discuss, nor am I going to test on, but you could definitely see them on NCLEX, so you're going to want to review those. The classification of disorders involves the structural development of the heart. So where is the structural issue? General signs and symptoms can differ in degree and severity given the specific defect. So you can have a very mild ventral septal defect, and you can have a very extreme ventral septal defect. Are they showing signs of congestive heart failure? Can we hear a heart murmur? If it's a mild defect, medication may be fine, and over time the heart, those holes and things can sometimes close. If it's more severe, it may require surgery or heart transplant. It's also classified, these heart defects are classified based on whether they're acyanotic or cyanotic. So acyanotic is when the blood is shunted from the left to the right. So the blood has already been oxygenated, it's shunting back to the right side of the heart and going back through the pulmonary circulation again. So it increases pulmonary blood flow and increases the workload of the lungs, but at least the oxygen that's going out to the tissues has been oxygenated. With a cyanotic defect, the blood is shunting from right to left. So it's not yet gone through the pulmonary circulation to get oxygenated. And so we're sending out blood that's unoxygenated. So we're decreasing pulmonary blood flow and sending out mixed blood flow. Some of it has been oxygenated, some of it has not been. So you can see why that would result in cyanosis of the child. Acyanotic defects that increase pulmonary blood flow are your atrial septal defect, your ventricular septal defect, which we're going to discuss in more detail, your patent ductus arteriosus, your arterioventricular canal, and then obstruction of blood flow under the acyanotic is coarctation of the aorta, aortic stenosis, and pulmonic stenosis. Your cyanotic defects that decrease pulmonary blood flow are your tetralogy of Fallot, which we're going to discuss in further detail, tricuspid atresia. Your mixed blood flow is the transposition of the great arteries and vessels, total anomalous pulmonary venous return, truncus arteriosus, and hypoplastic left heart syndrome. So increasing pulmonary blood flow is your ventricular septal defect. It's the most common heart defect in children. It's an opening between the right and left ventricle. It usually results in a loud, harsh murmur. If it's a mild defect, it can spontaneously close. If it's a more severe defect, it may require surgery to close it. And most of these surgeries, some surgeries now can be done almost through a catheterization type procedure, so they don't have to go through full open heart surgery, but it depends on the defect. They will require prophylactic antibiotics to prevent bacterial endocarditis. So this is those patients that require prophylactic antibiotics before they go to the dentist or undergo certain procedures to try to avoid the bacterial endocarditis, which is an infection in the heart itself and in the valves. So there's increased pulmonary blood flow. This is actually a young girl. So Megan's the one all the way on the right, and you can see how small she is compared to her friends. And then in the second picture, she's in the middle there, and you can see that by 13, it did not affect her growth, that she kind of caught up with her cohorts. Tetralogy of Fallot is 4 defects. It's a ventricular septal defect. It's an overriding aorta, so blood from both ventricles can now enter the aorta. Hypertrophy of the right ventricle, and stenosis of the pulmonary artery. This does require surgery to repair. Symptoms present usually in the first week of life, so this is usually diagnosed pretty early, is cyanosis, clubbing of the fingers and toes, dyspnea with feedings, squatting episodes. So the child actually gets in this knee-chest position, assumes a knee-chest position because it helps to, it actually helps the problem, which we'll talk about in a second. They go through these hypercyanotic episodes, which you can see in the picture. Lips turn blue, hands and feet turn blue. They're called TET spells. They can show symptoms of congestive heart failure. They can have poor weight gain, frequent respiratory infections, and polycythemia. So polycythemia is an increase in red blood cells. And the body does this as a compensatory mechanism. So it's not able, the heart's not able to oxygenate the blood properly. So the body compensates by making more red blood cells to try to carry more oxygen. Post-surgery, obviously this is a scary sight for the parents to see their child hooked up to all this equipment. Usually this is just maybe the first 24 hours post-op, and slowly a lot of those things start to disappear. So we're also going to talk about cellular regulation. So in a review of anemia, anemias are caused by destruction of red blood cells. So sickle cell anemia is generally evident by about 4 months of age. So it usually is not noticed at birth. I mean, they are screened for sickle cell at birth, but it's not usually apparent at birth because the destruction doesn't take place immediately. So usually about 4 months after, because of the maternal circulation while they're in utero. So sickle cell disease is a group of hereditary disorders. It's related to the presence of hemoglobin S. The most common forms of sickle cell disease are sickle cell anemia, sickle cell C disease, and sickle thalassemia disease. This is transmitted by a recessive gene, so it causes the red blood cells to change shape, and there's the sickle cell trait. So if you have two parents with the sickle cell trait, two of them, one of the children will be normal and not have the sickle cell trait, two will have the trait, and one will develop the disease. Sickle cell anemia causes clumping that can lead to thrombosis, which causes obstructions. Infarcts can develop in the spleen, the brain, the heart, the lungs, the GI tract, the kidneys, and the bones. Sickling occurs during periods of decreased oxygen, so you'll have venous pooling of blood. Triggers that put somebody in sickle cell crisis can be dehydration, infection, physical or emotional stress, exposure to cold, intense exercise, changes in altitude because there's less oxygen concentration as you get higher in altitude. So all of those things can trigger a sickle cell crisis. Clinical manifestations can be general. So during times when they're not in crisis, you may see like growth retardation, chronic anemia develop. During vaso-occlusive crisis, the presenting symptom is pain. So it's very painful. These patients come in extreme pain. You can see painful swelling of the hands and feet. They can have severe abdominal pain. They can have strokes and visual disturbances. They can have pneumonia, obstructive jaundice, hematuria. In the sequestration crisis, pooling of large amounts of blood in the liver and spleen cause them to enlarge and can cause circulatory collapse. You can also see decreased blood volume and shock. Vaso-occlusive phenomena, you can have like chronic cardiomegaly with murmur. You can have altered lung function, frequent pneumonia. The kidneys lose the ability to concentrate urine. They can have enuresis and progressive renal failure. The liver, you can have hepatomegaly, cirrhosis. The spleen, splenomegaly, and susceptibility to infection. The eyes, they can have blindness from the occlusions. Extremities, they can develop avascular necrosis of hips and shoulders, and they can also have strokes and seizures. One of the first symptoms is this dactylitis, which is unusual swelling of the fingers and toes. You can see in the picture. They can have drink excessively and urinate frequently. You can have difficulty toilet training these patients. They have chronic anemia, pale mucous membranes, fatigue, loss of appetite, joint swelling, and significant pain. Lab studies, we talked about the newborn screening, which is mandatory in the state of Pennsylvania. You can see hemoglobin levels that are a little lower than normal at 6 to 10. The reticulocyte count shows reticulocytosis. The Howell, Jolly bodies and Heinz bodies are specific to sickle cell anemia. They'll do liver function studies, renal function studies, ABGs, PFTs, EKGs, chest x-rays, again, looking for any of the complications of the sickle cell. Sickle cell crisis can be fatal. Patients will appear acutely ill, can have severe abdominal pain, muscle spasms, leg pain, painful joints, can run in temperature, vomiting, hematuria, convulsions, nuchal rigidity, jaundice, coma, and paralysis. So you want the interdisciplinary management of care to include supportive and symptomatic treatment, bed rest, trying to decrease oxygen usage, oxygen therapy, analgesics for the pain. Normally we're using morphine for that. Antibiotics for treat any kind of infections. You want to treat the dehydration. You want accurate INOs on these patients. Sometimes they require blood transfusions. They need IV fluids, daily weights, specific gravity of urine, monitor the hemoglobin and hematocrit. They need nutritional support, increase folic acid, and move joints gently and be supportive of them because, again, they're extremely painful. Okay, so the nursing diagnosis include ineffective tissue perfusion, caregiver role strain, risk for interrupted family processes, delayed growth and development, and impaired physical mobility. This concludes the podcast on cardiac and cellular issues.